Hello guys, this side your doctor Marksman, and today we will be studying medicine, and in that we will study chapter named Hepatology. We will try to cover and summarize this chapter in very short time as much as possible, and also we will be covering all the important points regarding this chapter. I'll be speaking in both of the languages. It will be mixed like Hindi plus English, whatever it is possible. Okay, so let's start. And in first thing we have, let us know the three main investigations, right? So first, what we need to check is first is LFT. Second, what we do need to check is ultrasound, and third is the fibroscan. In the fibroscan, what do we check? We check the degree of fibrosis, right? And then we come to the main aspect of anatomy and physiology of the liver. In that, the most important thing which we need to know is the detoxification, right? And also it has function which is more than 500. Okay, where is liver located? Right upper quadrant, right? Now we would like to know the view, like it has anterior view also, and also it has posterior view. And also in this they can ask you the questions like what are the segments and what are the parts. So what you need to know, like we have right lobe and left lobe. In the left lobe we have like segments, for example 2 3, then in the middle when we come it's 4, then 5 6 and 7 8, that time we go to right. Okay, in total we have 8 segments, and it is divided into two halves, and there is one line which is known as Quintiles line, right? Now we approach to the patient with the liver disease. So what we need to see in the ultrasound, what we will see first, we will see the liver size. Okay, cyst, any abscess present or any cancer present. Okay, and if we see the size is increased, then what we will say, it is hyperechoic, which is fatty liver. And it is, if the size is decreased, which is also called as hypoechoic, then it will be called as hepatitis, right? So whenever the size is decreased, nodules are present, altered ecotexture is there, serrated margins are there, shrunk fibrosis is there. Okay, whenever all these things are there, then we will call it as chronic liver disease or cirrhosis, right? Now we need to know the cells. First, what we will see is we see the hepatocytes, then we see the Kupffer cells, which is also called as like macrophages. Then we see the cells which are stellate cells, also called as ito cells, right? Now what we will see is, it was the first in ultrasound. This is what we all have seen, right? Now we will see the LFT, liver function test, right? In this, what we will see is, first let's see the just enzymes, and then we will see the bilirubin part. Okay, in enzymes we have albumin, globulin. Okay, what are they? Usually it is negative acute phase reactant. And when we see the bilirubin, if we see its increase, then what does it mean? It means that it is hepatitis. Either it can be chronic liver disease, obstructive jaundice, hemolytic anemia. These all things we can suspect, right? In this also there is one test which is also known as DISO test, right? Now comes the phases, right? First we see the acute phase reactant. What is this? Then enzymes. So whenever we have acute phase reactant, first is positive, second is negative. So whenever it's positive, then what all we can see? First we see the CRP, then we see ESR, then we see procalcitonin, we see IL, interleukin 1, interleukin 6, or ferritin. So whenever it's present, all these things we can see. Whenever it's negative, then what we will see? We will see albumin or globulin, right? Now come the enzymes. In LFT, when we see the enzymes, so what we have, either it can be hepatocyte death or it can be cholestasis, right? Whenever it's hepatocyte death, then we will see two things. Either it can be AST, or it is also called as SGOT, or it was AST, SGOT, second is ALT and SGPT, right? So these are the two enzymes which we will see. And in the cholestasis we see liver, gallbladder, bile duct. So that's okay, but we have to main focus on the AST and ALT part. Whenever it's AST, in that what we will see, like in Hindi we say like sharab, so it's S means sharab, so it's sharab specific. And whenever it is L, that is liver specific. So whenever it's AST, so what we will see is, if AST is more than ALT, right, sharab is more than liver, then what we'll see? We will see acute liver disease. Okay, because it's just S is there which is increased. Whenever it will be opposite, like ALT will be increased, then it will be viral specific, right? So now we have three parameters AST by ALT we divide. So whenever AST by ALT is more than 2:1, okay, then it will be suggestive alcohol, okay. And whenever AST by ALT is more than 1, then it will be cirrhosis, right? And whenever AST by ALT is less than 1, then it will be chronic viral hepatitis, right? So now we see then what we will see is we see AST. When it's more, it's for alcohol. When ALT is more, it's viral screening. So whenever ALT is more, which is also called as viral screening, what we will see is we will see first HbSAg and anti-HbC. So whenever HbSAg we find, then that means we will rule out hepatitis B. And whenever we see anti-HCV, then we will rule out hepatitis C, which are more dangerous. Then what they will ask you the sequence, right? So AST by ALT is the one which is the most. Then we see AST, then we see the GGT. Guys, I would say that do not ignore this GGT because it's the one which is the most specific marker for alcoholism. This can be a potential question which could be asked, right? Now we come to the second part and we see what is this ALD, which I told that acute liver disease, right? So in acute liver disease, so we have three components in this. First is alcohol fatty liver, then we have alcohol hepatitis, and then we have alcohol cirrhosis, right? So in alcohol fatty liver, what we see? See, alcohol is there. A person has drank so much alcohol and the liver has become fat, which is called as fatty. So that means that person who has been yes. So we were on ALD and we have three things: alcohol fatty liver, alcohol hepatitis, alcohol cirrhosis. So in alcohol fatty liver, we have chronic alcohol. It will be 5 to 10 years and there will be no symptoms at all because maximum things will be normal. For example, the LFT is normal, ultrasound will be hyperechoic, okay. In diagnosis, how can we see? We can see by ultrasound. And also if we see a treatment, just stop the alcohol and just do the weight loss, everything will be fine. Now comes alcohol hepatitis and alcohol cirrhosis. In alcohol hepatitis, it's like it will start from the binge drinking, okay. And where will the pain? It will be the right upper quadrant pain, okay. In LFT, what you will see in alcohol hepatitis, LFT will be deranged. In ultrasound, what you will see? You will see hypoechoic, okay. In treatment, what you will give? You will give IV of dextrose plus MV, which is multivitamin. And also what you can see is pentoxifylline, okay. And there is a factor through which you see it. It is called as MADRS discriminant factor, which is more than 32, okay. And the drug of choice of the alcohol hepatitis is steroids, okay. Now comes the alcohol cirrhosis. In alcohol cirrhosis, what you see? It is also chronic alcohol. It's usually 10 to 15 years, okay. And in this, because now it's already a lot of the time it has happened. So now what we will do is in the treatment, we will just transplant the liver, nothing else, okay. So for the risk factor, what we will see is quantity. First we will see male and female, okay. So for the male, quantity is 40 to 80 gram per daily, and also in the females we see 20 to 40 gram per daily, right? And also it's more in the female, okay. Also depends on the quality, obesity, diabetes, okay, hepatitis C, all these things are there, okay. Then we will see a question comes about the cage questions. So what is this? First of all, it is used for the alcohol addictive people, okay. So usually why it is called cage? Because it starts from the four things CAGE. So C means cut down. So what is cut down? Okay, it's cut down on your drinking, okay. It's like questions which do we ask? It is annoyed, like have people have been annoyed by the drinking. Then G is guilty, have been people guilty about the drinking. Then E, cage, E means eye opening drink, okay. So like when that means like are you rid of your hangover, which is eye opener. So these are the four things. Let me repeat again. CAG, C means cut down, A means annoyed, G means guilty, E means eye drink. So these are the four things which you need to look for the cage questions, right? So now we see the drug of choice. See, there are three things. Either you are addicted to alcohol, which is alcohol addict. Second is alcohol withdrawal. Third is alcohol toxicity. So if you are addict, okay, so in that case, what do we use? You have to use for the drug of choices, disulfiram, right? In that also you have some anti-craving agents, okay. it could be like many other. For example, we use a NOTA, for example, that is naltrexone, ondansetron, topiramate, acamprosate, right? For the alcohol withdrawal, we use benzodiazepines because you need to withdraw. Okay, and if you have toxicity, then what do we use is formipizole, right? These are the things. And also, for if you want to see the long acting drugs, then you can see chlordiazepoxide or diazepam. Okay, but it's contraindicated these two if LFT is deranged. So what are these two? Lorazepam and oxazepam. Okay, so these are the things which we have done, and now let's see the carbohydrate deficit transferrin, right? So in that carbohydrate, what you need to see is non-alcoholic fatty liver disease, okay, and NASH. So these are the two things for which we need to differentiate. In non-alcoholic fatty liver disease, what we need to see is, see, it's non-alcoholic na, so no symptom. It will be hyperechoic. Okay, in this the LFT will be normal. In this there will be no inflammation, there will be no necrosis. Okay, usually it's no side, right? Now the main thing is NASH. This we need to see because it has pain. Okay, it has nausea, vomiting, and also it has hypoechoic, not hyper. Okay, in this the LFT will also be deranged. In this there will be inflammation, in this there will be necrosis. So usually all the problems are there is NASH. Okay, now what we see is, we can see the risk factor of both of them. It's which is chronic liver disease. So what risk factors are? Junk food, okay, skipping of meals, usually breakfast, okay, it's usually for the obesity people, diabetic people, metabolic syndrome. Okay, in this also ferritin level is increased. So all these things are there, steroids, obesity. So these are the risk factors. Now let's see the treatment of both of them. We will see individually. For non-alcoholic fatty liver disease, the treatment is weight loss, vitamin E, okay, omega-3, coffee, okay, pioglitazone. These are the drugs, but treatment of choice is weight loss. Okay, and for this NASH, what we will do is give is IVF plus multivitamin. Okay, now we will see a score which is called as BARD score, which is used in NAFLD. Okay, non-alcoholic fatty liver disease. So B is BMI, A is AST by ALT, R is ratio, and D is diabetes. So this was all the related stuff which we talked. Now let's come to acute viral hepatitis. So this I would like to say because many of the questions come from it, and also it come in various ways. So we all know there are A, B, C, D, E, 5 types of hepatitis. Okay, and first we will see the family. So we may have many mnemonics. So what we have here is PH full dangerous है. So P means picorna, H means hepatidina virus, hepatidina family, and F is flavi, D is dangerous, H means hepa. Okay, hepatitis wala. So we have these families. So what we need to know is, so these are means whatever I told, these all were just the acute viral hepatitis. We have 5, A, B, C, D, E. So in A we have picorna virus, then hepatidina virus, flavivirus, delta virus, epivirus. Okay, so the main thing is we need to know which of them are DNA, which of them are RNA. Only there is one which has DNA, which is hepatitis B, right? Then we come to the root. So majority of them are blood, but there are only 2, which is fecal-oral route, A and E. Then comes enveloped, oral enveloped, except 2, the same, A and E, which is unenveloped, right? Then comes, we see which all are acute, which all are chronic. So there is only one which is chronic, which is hepatitis C. Okay. Then comes the cancers, which if you can leave also no problem. Okay. So now comes most common cause of acute hepatitis is alcohol, because it's acute, right? And if they say the most common cause of acute viral hepatitis, when it will become viral, then it will be hepatitis A more than hepatitis E, because A is in children, E is in adult. Okay, because it's viral. And if it comes to fulminant hepatitis, okay, then it will be toxin, which is more than hepatitis D. Now comes most common cause of acute viral hepatitis. It's children, which I told. Now we will talk selectively about all hepatitis A, E, B, okay, and then we D. So like this we will talk separately. So let's talk about hepatitis A. It's C. It starts with right upper quadrant pain, nausea, vomiting, abdominal pain, fever, jaundice. Okay. Ultrasound will be hypoechoic. Okay. In LFT there will be increased bilirubin, increased enzymes. Okay. ALT will be increased. So in diagnosis and treatment, in diagnosis what we will see IgM, okay, IgM anti-HAV, and then the treatment what we will give IVF or good diet. This was all about hepatitis A. Let's talk about hepatitis E. E is expectant or pregnant. So usually we will see this all in the pregnant ladies, right? So mild disease in non-pregnant population, and also there will be treatment which will be self-limiting. In pregnancy what we will see is fulminant hepatitis. Okay, in treatment what we will give ribavirin. Okay, and there is no vaccine for it. Then comes hepatitis B. So we have 95% and 5%. In hepatitis B, 95% is acute, which is self-limiting. 5% is our chronic, right? So in chronic, what we will see? First, we will see that LFT are increased into 2 times, and also we have DNA copies which are more than 20,000, right? And if patient in chronic liver disease has DNA copies more than 2,000, then we call it chronic. Okay. So what we will see is first, let me give you a more idea about it. See, we have 2 things: acute, chronic, right? Acute is self-limiting, and chronic. And when we come to chronic, we have 2 things: early or late. Whenever it's early, that means DNA copies are more than 20,000, and AST and ALT level are into 2 times, right? And when it's late, that means DNA copies are more than 2,000. Okay. So these all are the things. And also in hepatitis B, they will ask you about the this injuries which is called as needle prick injury. Okay, and also it is sexually, and also it is vertically. So these are the routes which are used in hepatitis B. The treatment we give is tenofovir or anti-cavir. Okay, then comes about hepatitis B markers, right? So we have, see, I will tell you from starting. First we have 3 antigen and then 3 antibodies. In the antigen part we have S, C, E, C, E, S. So in S means hepatitis S antigen is positive, that means entry. Hepatitis C antigen means not detected. SCE, E antigen means divided or replicating, which is infective. Okay, then comes 3 were antibodies. So anti-HBC, anti-HBE, anti-HBS. When it's anti-HBC, then we have 2 things: IgM, IgG. Whenever it's IgM, it's acute. Whenever it's IgG, it's chronic. And whenever it's anti-HBE, that means it's non-infective. Anti-HBS is cured. So these are the things which we need to know. So there are certain points which I will tell you later on, but first let's start from hepatitis D. It has 2 things: co-infection, superinfection. Co-infection means 2 things are together, hepatitis B and D. In superinfection, it's initially with hepatitis B, later on it will convert to hepatitis D, right? So whenever you find 2 things together, co-infection, first B and then D, that means it's superinfection. So there are certain points which I would like to tell you is, they will ask you about, okay, which of them is vaccinated. So if they ask the vaccinated, you need to tell the anti-HBS is positive. Okay, which one? Anti-HBS. Okay, it means the person is cured. If they will ask you what is window period, so you need to know that whenever you have anti-IgM, okay, anti-HBM, SBC is positive, then it's window period. Okay, and whenever they ask you what is HBeAg, that means it's a pre-code mutant or Russian variant. And whenever they ask you what is escape mutant, then it's anti-HBsAg. Okay, so these were the things which I told about everything. Let's come out chronic viral hepatitis. In this, what you need to know is hepatitis C, either whenever it's subclinical or it's asymptomatic. So these are the usually late presentation of the viral hepatitis. So what you have is diagnostic and treatment. Anti-HBC is a diagnostic, and we treat all of them. So whenever we have three stages, early, late or very late. So whenever it's early stage, what you give is sofosbuvir or declatasvir. Okay, so one thing is common, sofosbuvir is common, three of them, either it's early, late or very late. The things which are changing that I would like to tell you is, in the early is declatasvir in early, in late velapatsvir, okay, and in very late we have velapatsvir plus ribavirin. So these are the things which we need to know of usually drugs. Okay, so let's move forward and we see the other stuffs which are being required here. So what we see is extra hepatic manifestation. Okay, in this we have hepatitis B and C. In B we have PAN, MGN, mixed cryoglobulinemia. In C we have lichen planus vitiligo and mixed cryoglobulinemia. Okay, now we have autoimmune hepatitis. Let's see it. Okay, so what is this? In this we have diagnostic of exclusion. In this there is an antibody ANA which is positive. In this there is anti-LKM, anti-SMA, anti-LCA, atypical P ANCA. These all are positive. Okay, females are more than male. In treatment it's steroids. Okay, which is good prognosis. In AIH we have cirrhosis, chronic liver disease, which is used for liver transplantation. The main thing is autoimmune hepatitis is this reoccurs even after transplantation. Okay, then we have alpha 1 antitrypsin deficiency. In this we have alpha 1 antitrypsin which protects. In lungs we have pan acina emphysema. Okay, in this autoimmune we have like genes. So if it is PIMM, that is the only one which that means it's normal. If you have any other, for example, if you have only PIM, it's not normal. Only PI, not normal. PIMZ, not normal. And if you have PIZZ, it's the most dangerous one, right? So in lungs, what I told, pan acina emphysema, and liver we have cirrhosis, alpha 1 antitrypsin. Okay, so these are the ones which are there in alpha 1 antitrypsin deficiency. Then comes cirrhosis. In cirrhosis we have alcohol, viruses, Wilson disease, hemochromatosis, PBC, PSC. All these things are there. Also Indian childhood cirrhosis. So what we need to know about cirrhosis is, first of all, clinical features. These are important ones. Where pain will be right upper quadrant pain, bilirubin will be increased. So jaundice, icterus. Okay. So these are the important points now which I will be telling you now. These are the ones which increase estrogen. Gynecomastia we have, palmar erythema, spider angioma, infertility. Okay, so these are the four things. Either being a clinical feature of cirrhosis, this also increases the estrogen. Now we have other points also. For example, ascites, caput medusae, periumbilical vein, esophageal varices, which ruptures and forms hematemesis, right? Then we have piles, which is blood in stool. So these are the 4 points. Besides being there in clinical feature of cirrhosis, this is also there in portal hypertension, right? So now let's talk about more about ascites, which we read as a clinical feature. So in ascites, what you will find is, first of all, where it will be in chronic liver disease, okay, in TB, okay, nephrotic or Budd-Chiari syndrome. In these things we find. In ultrasound, what you will see, coarse liver, decrease in size, altered echo texture, nodules. In nodules, 2, either it's less than 3 or more than 3. Whenever it's less than 3, it's micronodular, poor prognosis, alcohol. Whenever it's more than 3, macronodular, good prognosis and viral. So in this, when we see, then we have 4 vials. Okay, first we have micro lab, culture, gram strain, AFB, and when we see second is chemistry. In biochemistry, what we see is proteins or albumin. Okay, in pathology we will see cells, atypical cells, force can be preserved, right? So these were the clinical features and diagnostics which we have seen right now. And also in this, there we have some diagrams in which I will be telling some main stuff which shows that first, whenever we have cirrhosis, there will be protein which will be low, there will be SAAG which will be high. So these are the 3 things which you need to know. Okay, then comes treatment of ascites. In treatment of ascites, what we do is low salt diet or salt restriction. Okay, or what we do is we can do diuretics. In that, we have to do is KFT plus electrolyte. Okay, in this we have furosemide, which we give 20 milligram to 160 milligram, then spironolactone 50 milligram to 400 milligram. This all which I have told you, low salt diet restriction, do KFT, electrolyte, what all these things are, these all are refractory ascites, which is large volume paracentesis, right? So these all are things about ascites. Now I will be telling you the spontaneous bacterial peritonitis. Peritonitis, what it is. Most common is E. coli. Total leukocyte count is more than 500. Neutrophil is more than 250. Okay, this is the treatment is important one. Cefotaxamine, ceftriaxone, which is given into 5 to 7 days, right? In prophylaxis, norfloxacin. Okay, so I talked about spontaneous bacterial peritonitis. Now I will be talking about hepatorenal syndrome. See, hepato means liver, renal means kidney. So two things are combined and then it forms a syndrome. Okay, so let's see, we have two things, type 1, type 2. Type 1 is what? Doubling of serum creatinine. Okay, and also there will be half of GFR and it will be less than 2 weeks. In type 2 there will be increase in serum creatinine but not doubling. Second, it will not be half, it will be decrease in GFR. And third will be over few weeks and gradually it will develop, right? In this will be diagnostic of exclusion. There will be no prior CKD, no AKI, use of nephrotoxic drugs, nothing, right? In treatment, what we see is midodrine, terlipressin, liver and kidney transplant. Okay, so liver and kidney transplant, this is the best modality which we have right now for that. Okay, so what I talked about was the hepatorenal syndrome. Now I'll be talking about hepatopulmonary syndrome. Say hepato is liver, pulmonary is lungs. In this, what we have is shortness of breath, orthodoxia, platypnea. So these are the three things. In diagnostic, what we see is bubble echo sound, and in treatment, what we do is supportive. So these all were the things about hepatopulmonary syndrome. Now let me talk about varices. What is varices? This is a kind of bleeding, chronic liver disease. Okay, chronic liver disease that leads to varices, and if it ruptures, that leads to massive hematemesis. Okay, so whenever it's chronic alcohol, we have to give the treatment. Treatment is octreotide. Okay, terlipressin. Okay, later on we can give endoscopic band ligation. Then we can give TIPS, transjugular intrahepatic portohepatic shunt, and at the end we do is liver transplantation. In the prophylaxis, what we do is propranolol, beta blocker, right? So these things which we have done. Now let me talk about hepatic encephalopathy. This is seen in patients with liver disease. So we have three types: type A, type B, type C. Okay, type A we have acute liver failure. In this, what we have is toxins which are more than hepatitis B or E. Sorry, hepatitis D or E. Okay, in this we have fulminant hepatitis failure. So this was type A. Now we go to type B. It has big shunt. This is also called as TIPS. Then we have type C, which is also called a chronic liver disease or most common. In this we have compliance disturbed or medicine. We have hypoxia, alcohol, constipation. So these were the things which we find in type C, right? So in the hepatic encephalopathy, which is reversible encephalopathy, in this, when we see the diagnostic, what we see is serum ammonia. Okay, ammonia level will be high. Ammonia, GABA, mercaptan. Okay, in the treatment, what we do is lactulose. Okay, antibiotics are unlikely to precipitate. We can give rifaximin. Okay, we can give L-ornithine, L-aspartate, ondanset, PPI, whey protein, benzodiazepines. These things we can give. Also, this can alter the sleep cycle, decrease attention, drowsy, hysteresis, which is flapping tremors, ECG changes, stupor, and coma. Earlier symptom is alteration in sleep pattern. Okay, so these were the things about hepatic encephalopathy. Now let me talk about two things: primary biliary cholangitis primary sclerosing cholangitis. Whenever it's biliary cholangitis, it's intrahepatic. Okay, antimitochondrial antibody which is associated with S-Jogren syndrome. Also, it is in diagnosis liver biopsy and AMA. We can see in treatment of choice, it is liver transplantation. Whenever it's primary sclerosing cholangitis, what we see is cholangiocarcinoma. Okay, it's not intrahepatic, it's extrahepatic. Okay, there it was AMA antibody, it's Pianka antibody here. Okay, there it was Sjogren syndrome, here it is ulcerative colitis. Okay, here diagnostic will be ERCP, MRCP, which we can see purloin sting or beaded appearance. Here also what we do is liver transplantation. There are things which are common in both of them. Most common symptom is fatigue, which is more than pruritus. Then ALP and GGT both will be increased. Drug of choice will be UDCA, ureodeoxycholic acid. Okay. So these were things about PBC and PSC. Now let me talk about hyperbilirubinemia. In this, what we have is first is hemoglobin that will go to urine, unconjugated bilirubin. Then comes conjugated bilirubin, and then comes later. Okay. So in this, main thing what you need to know is UGC. Just remember, right? In this, U is unconjugated. Okay. And whenever you have unconjugated, then what you see? You see Krigler-Najjar and Gilbert, right? These are the two things which is there in unconjugated, and whenever you want to see the conjugated one, you need to know two things: Dobbin-Johnson and Rotor syndrome. Okay. Then comes Wilson disease. Okay. In the Wilson disease, what do you need to know is ATP 7B or chromosome 13. Okay. In this, the copper transport is defective. Okay. What you need to know is there are some we have mnemonics also, or you can learn like directly also. So like we have P and sleep, for example. When you sleep, okay, so what will happen is sleep and go to urine, washroom, so it increases copper in urine. Okay. So, and also second thing is study, that means CNS. So whenever you see, so there will be dystonia, and secondly Parkinsonism disease. In mall, what you see is liver, L is there in the liver, so that means that will be cirrhosis. When you go to movie, what you see? Eyes. So in eyes you have KF ring and sunflower cataract. Okay. So in diagnosis, what you see is first there will be one thing which will be decreased, that will be copper screening. Copper will be decreased, but all things will be increased. Urine copper will be the ceruloplasmin, which is the thing which is decreased is serum ceruloplasmin. Thing which will be increased is urine copper. Investigation of choices, liver biopsy. Okay, slit lamp in examination we see KF ring. Okay, and we can see a genetic testing also. In treatment, what we do is zinc acetate, which is a drug of choice, and then what we can give is penicillamine. Okay, and also we can give is tetrathiomolybdate. We can give. Okay, and also there is one index called Najjar prognostic index, which in which there will be SBIV called as S is SGOT, B bilirubin, I is INR. Okay. So if it is 7 to 9, it's physician choice. It is more than 9 is liver transplantation. Less than 7 is we can manage this by medication also. In zinc, we need to know is Wilson disease, diarrhea, echodermatitis, increase immunity, decrease inflammation. All these things we can see. Okay. So now how to diagnose it? We can see by serum ceruloplasmin, which will decrease. KF ring, we can see slit lamp examination. Urine copper will be increased. In liver biopsy, we can see which is the investigation of choice. Okay, so this was all about zinc. Now let's see about hematochromatosis, which is also called as iron overload. In this, there will be first degree and second degree. In first degree, what we have is we have a gene C282Y, which is also called as HFE gene. In skin, we have bronzing. Liver, we have cirrhosis. Joint, we have arthralgia. Pancreas, we can see insulin. Okay, pituitary. In pituitary, what we can see is hypogonadic tropic hypogonadism, right? And there will be no testis. In second degree, what we can see is axis blood transfusion, axis iron transplantation. Sorry, not transplantation, is supplementation. Okay, so in this, how do we diagnose it? Iron wala, we can diagnose it by serum ferritin, initially monitoring. Second, what we can do is liver biopsy, we can see. Okay, and in this we can see the hepatic iron index, which is Prussian blue. Treatment, what we can do is phlebotomy, treatment of choice, and desferrioxamine, right? So these all the things which we can see. Now let me summarize you everything within some time by telling you some scores. We have, for example, first we have MELD score, which is there for the end stage liver disease. Okay, which is also called as CBI, we called it, which I told you already. Then we have PELD score, pediatric end stage liver disease. In this, what do we have is, we have bilirubin, INR, okay, albumin, age, and nutrition status. Okay, which is also called, we can call this baby NEBBA, nutritional status. Okay, INR, bilirubin, albumin, age. Okay, third is nasal index, which is liver transpartin Wilson, which I told you already. SBI, S is SGOT, B is bilirubin, I is INR. Then fourth we have is Madrid discriminant score, which is there for acute hepatitis. It should be more than 32. Okay, INR. Then fifth we have a child per classification score. In this we have A, B, C, D, E, F. A is albumin, B bilirubin, C is clotting, fourth is distension, fifth is encephalopathy. So guys, I have summarized everything within, I tried my best possible time, within less time how much it would have been possible. I'll try my best to give you some more videos and more contents for you to study. I hope you liked my video. Thank you guys. Your doctor, Dr. Masman. Bye.